menstrual cycle, its phases, hormonal control of the menstrual cycle, changes that happen in the ovaries and in the endometrium. We will discuss different abnormalities of menstrual cycle and distinguish between primary and secondary amenorrhea. Our patient today is a 20-year-old woman who presents with the absence of menses for 4 months. Before this, she experienced 2 months of very heavy, prolonged menstrual bleeding, which required the pads change every 1 to 2 hours. She also reports increasing fatigue and occasional lightheadedness. Her cycles previously were regular at 30 days. She is sexually active with her husband and uses no contraception. She denies galactorrhea, headaches, visual changes, or hot flashes. She has gained 6 kilos over the past year and reports increased stress at work. Physical exam shows obese woman, BMI 29. It's a huge distractor.
Sorry. You should get ice cream after. It was very good.
Thank you. Is it pistachios? Pistachio?
No, cookies and cream. Actually, no, sorry, cookie dough. There we go.
So thyroid size is normal. She does not have hirsutism or acne and no galactorrhea. Pelvic exam shows normal external genitalia, normal size uterus, no adnexal masses. So laboratory findings: urine pregnancy test negative. Whenever there is amenorrhea, first thing that is done is pregnancy test. Because amenorrhea, as you understand, can be physiological, and if the woman is not breastfeeding, and of course the doctor would know about this, then pregnancy test is done, especially if the woman is of the fertile age. Hemoglobin is low, and that is the reason why she has lightheadedness and fatigue. TSH is mildly elevated, but we see that thyroid size is not affected. TSH is elevated in hyper or hypothyroidism. In both, right? Can be increased in both. Hyper or hypo. Because if it is increased, and this is what causes, you remember what TSH does to the gland? It stimulates secretion of T3 and T4. By activating many enzymes, it causes proliferation of the cells and overall increased size. It stimulates secretion of the colloid in the follicles, so increases the size of the mass. So if it was secondary hyperthyroidism, right? Primary we're talking about primary hypothyroidism can, by negative impact, increase TSH, right? At the same time, secondary hyperthyroidism starts with high TSH. So high TSH may be in both hypo or hyper, depending on whether it is primary or secondary. But usually TSH would always enlarge the thyroid gland. Here it is normal just because TSH is mildly increased. Hypothyroidism is often associated with amenorrhea and infertility, leads to anovulatory cycles. Prolactin is another hormone that potentially could cause amenorrhea, again through this same TRH axis, because prolactin, if it is high prolactin, TRH is considered to be stimulatory for prolactin secretion, right? FSH/LH low normal, estradiol low normal, so which tells us that maybe LH surge never reaches the peak, which means that there is never ovulation. Estradiol is low, so that's initially low estradiol that affects the peak of LH, or it may be initial changes in LH and FSH secretion that does not allow estradiol to rise, that affect the ovary, whatever, but these hormones are low at the lower end. Nothing much, mild changes everywhere, but still. Pelvic ultrasound shows thickened endometrium, but no masses. So she does not have any cancer, no adnexal masses, no uterine masses. She has gained weight and reports increased stress at work, which may mean that she has a high, which type of hormones may be high? Cortisol and CRH may be high, which would inhibit the axis, right? And can cause amenorrhea by itself without anything else. Stress-induced amenorrhea. Because we remember that CRH suppresses pulsatility of gonadotropin-releasing hormone secretion. So we will answer these questions on the case by the end of the lecture. So we will discuss if the patient has secondary or primary amenorrhea, what is the normal menstrual cycle, how it changes in adolescence and perimenopause, what is the duration of her luteal phase and follicular phase based on her previously normal cycle, why she developed menorrhagia, and how contraceptives can be helpful in treatment. So menstrual cycle is regular cyclic changes that occur in the reproductive system of the female, and menstruation is the only part of menstrual cycle. As you can see here, menses or menstrual flow, which is periodic bleeding through vagina, is part of the uterine phase. On the whole, we are talking about two levels of control with regards to reproductive system, that is ovarian level and endometrial level. So we see that the changes during the menstrual cycle are taking place in ovaries, and they're taking place in the uterus with regards to endometrium. And that's why we name the phases differently, depending on where it is happening. So with regards to ovaries, we name the phases follicular and luteal, exactly like we discussed when we talked about secretion of hormones. Growth of follicles, and then at day 14, ovulation and secretion of progesterone by corpus luteum. In the endometrium, there are three phases, as you can see, because menses, which is menstrual flow or the flow of blood through vagina, is part of the changes of the endometrium, and menses and further proliferation and growth of the endometrial layer after the upper 2/3 of it were shedded during the menstruation is a part of a follicular phase. So this develop under the influence of high estradiol. After ovulation, there is secretory phase in the endometrium, which corresponds to the luteal phase in the ovary. And during secretory phase, the glands actively grow, the vessels grow in the endometrium. The average duration of the menstrual cycle is 28 days plus minus 7. So here throughout the whole lecture and for the teaching purposes, we will use 28 in most cases, if otherwise it will be specified, we will use 28-day duration menstrual cycle. And we already mentioned last time that the duration of luteal phase is fixed at 14 days always. Why? Yes, because it depends on the lifespan of the corpus luteum. It survives for 14 days. It survives for 14 days if implantation of fertilized egg did not take place. So if not pregnancy, in non-gravid women, it survives for 14 days. Of course, if pregnancy took place, and we will talk about this later in the next lecture, corpus luteum sustains pregnancy because progesterone secreted from corpus luteum is the major hormone that sustains pregnancy by decreasing contractility of the uterus. And it has to stay until placenta can take over and start secreting enough of progesterone to keep sustaining pregnancy. For this, placenta has to simply grow in size enough. And this happens at week 8 to 10. So, let's talk about the duration of follicular phase, which may be different depending on the length of the cycle. So let's talk about 24-day cycle. What would be the duration of follicular phase? 14? No, follicular phase. Luteal phase is 14 days, as it is always 14, whatever is the duration of the cycle. But if the cycle is 24 days instead of 28, then to find out the duration of follicular phase or the day of ovulation, you need to subtract, right, 14 from 24. 10. So on which day would be ovulation? 10. Day 10, right. If the cycle is 35 days, ovulation would be on day 35 minus 14, day 21, right? Ovulation on day 21, which means that follicular phase is 21 days and luteal phase same 14. In reality, follicular phase can also be different, but for the testing purposes here, for the board exams, so you have to remember that luteal phase is 14 days. Okay? So since the changes are taking place in both ovaries and endometrium, we will be looking at ovarian cycle and endometrial cycle. So in the ovaries, we are talking about follicular and luteal phase. In the endometrium, proliferative and secretory. Menstrual cycle has 4 levels of control. And these levels of control are hypothalamus, pituitary, and then ovary and endometrium, due to the secretion of ovarian hormones and changes in the endometrium. So, as we already discussed, ovary secretes different hormones, some of them steroid, others polypeptide. And all of the hormones of the ovary provide feedback on the anterior pituitary and hypothalamus, some of them. So estradiol has this unique influence because it's only estradiol that provides both negative and positive feedback control. Progesterone also provides feedback. But feedback of progesterone is always inhibitory. Inhibins also provide feedback, but inhibins feedback, even by their name, is also always inhibitory on FSH secretion. And it's only estradiol that can provide both negative and positive feedback, and its feedback, type of feedback, negative or positive, depends on its concentration. So normal physiological concentration, beginning of the cycle, beginning of follicular phase, right after menses, and end of luteal phase is negative. Negative on enteric pituitary, negative on hypothalamus. Decrease of gonadotropin releasing hormone, decrease of tropic hormones, FSH and LH. And only in the middle of the cycle, right before the ovulation itself, so on day 14 or day 13, if we are talking about 28-day cycle, when estradiol concentration rises enough due to high level of secretion from granulosa cells, this feedback becomes positive. So estradiol additionally stimulates and this positive feedback on enteric pituitary to cause LH and FSH surge. Both increase, but LH increases much higher since it has fast waves, high magnitude waves and high magnitude surge, and it is LH surge that is important for ovulation. Follicular phase. Again, I'm not going to go into the detail of follicular growth and development layers, but of all the primordial follicles, which are several hundred thousands in both ovaries at birth, and the number never changes, never increases, only decreases throughout the reproductive life of a woman. One or two are chosen for the growth, and it's AMH that restricts the number of primordial follicles that are recruited to maintain the ovarian pool. So as primordial follicles grow, the number of granulosa and theca cells increase, the number of layers formed by granulosa cells increase, and they secrete more and more estradiol. Finally, estradiol would activate certain enzymes in the follicles, so this would cause the swelling of the vessels under the influence of prostaglandins and other pro-inflammatory mediators, and it would cause the rupture of the follicle with the release of oocyte covered by corona radiata, one layer of granule cells, into the peritoneal cavity. The cavity, which was initially filled with Graafian fluid, the cavity of the follicle becomes filled with blood as the vessels are ruptured, that's corpus hemorrhagicum, and very quickly it is turned into corpus luteum. So that's luteinization, which gives this yellow color to the corpus luteum due to the droplets of lipids which are inside every theca and granulosa cell. And then corpus luteum survives for 14 days and undergoes degradation, substituted with scar tissue, and forms corpus albicans. I'm not testing you on that scheme. You don't need to learn every detail here, okay? It's just for you to understand how ovulation is taking place. So it's really under the influence of estradiol, high secretion of estradiol, that causes LH and FSH surge. LH is more important for ovulation, and then LH affecting granulosa cell causes secretion of progesterones, there, prostaglandins, thromboxans, leukotrienes, those pro-inflammatory mediators that cause pseudo-inflammatory response in the vascular wall, causing the swelling of the follicle and plasma transudation into the follicular cavity, which would eventually increase the follicular volume, increase the pressure inside the follicle, and cause the rupture of the follicle with further formation of the corpus luteum and release of the ovum inside the peritoneal cavity. After the ovulation, a luteal phase starts in the ovaries. So follicle collapses, but then luteinized quickly, and corpus luteum is formed. So granulosa and Deca cells are both luteinized, and they start secreting hormones together. The major one is progesterone, but also they secrete enough of estrogens. So compared to pre-ovulatory state and compared to right post-ovulation, the amount of estrogens from corpus luteum increases. Corpus luteum undergoes several phases. It undergoes proliferation, increase in size, secretion, and finally regression. Inhibin is also secreted, just inhibin A, as you remember, so there is feedback negative control on FSH. Finally, lysis, so destruction of the corpus luteum, forms corpus albicans. Endometrial cycle shows the changes in the endometrium. And here we are talking about three phases. Menstruation. The first day of menstruation is the first day of the cycle. So these 3 to 5 days of menstruation are part of the endometrial cycle, followed by proliferation of the endometrium and growth of vessels and glands, active secretion of the glands, secretory phase, which corresponds to the luteal phase and is under progesterone control. So menstruation is shedding of the functional layer of the endometrium, where upper 2/3 of the endometrium are destroyed and shedded. So that's basically arterial blood that is there in the menstrual flow with tissue debris, prostaglandins, mucus, leukocytes, and other cells. So this graph illustrates the hormonal changes throughout the menstrual cycle. And here in the middle of the cycle, right prior to ovulation, maybe 12 hours before the ovulation, there is a LH surge and FSH. FSH much lower, but nevertheless also increases. So LH FSH surge is under the influence of estradiol positive feedback. You can see that right before preceding LH surge, there is surge in estradiol. Blue curve shows secretion of estradiol, and it has two peaks. First peak is when estradiol is secreted by granulosa and Teca cells of the follicles, and second peak is estradiol secreted by granulosa luteal and Teca luteal cells in the corpus luteum. Progesterone is secreted by corpus luteum only, coming from granulosa cells of corpus luteum, and again it is low throughout all of the follicular phase and high in luteal phase. So that's the major product of secrete by corpus luteum. Inhibins also shows two peaks, and the major peak is by inhibin B, secreted by inhibin E, secreted by corpus luteum, and the first peak is inhibin B by granulosa cells of the follicles. Inhibin inhibits FSH. Cervical mucus undergoes changes during the cycle, and these changes are different in follicular and luteal or secretory phase. That is because the changes are produced by different hormones. Last lecture we already discussed the influence of estrogen and progesterone on the quality of the mucus. So under the influence of estrogen in the first phase, the mucus is very thin, stringy, with alkaline pH. So this is a spin bucket test. that shows when mucus is placed on the slide, it forms the strings. And this quality of mucus, thin, slight alkali pH, is promoting the movement, easy movement of spermatozoids from the vagina to, through the cervix and towards the uterus to fertilize the egg. When this mucus dries on the slide, it forms this characteristic ferning pattern, so it looks like fern leaves. This pattern is created also by many biological fluids, like, for example, saliva, nasal fluid, which is from the nasal fluid, throat. They all would be creating certain pattern because of the presence of salts there. So that's crystals of salts that after drying form this characteristic pattern. But when we are talking about cervical mucus, this ferning pattern is formed only by mucus in the follicular phase. Mucus in the luteal phase or secretory phase becomes very thick, slightly acidic, which seals the cervix, prevents the movement of spermatozoids, seals the cervix from spermatozoids and bacteria, which is important, especially in case fertilization and implantation took place. And this mucus does not form, this doesn't have this ferning pattern. So what are the indicators of ovulation? That is increase in the basal body temperature because of rise in progesterone. That is a change in the cervical mucus nature. No ferning pattern, no thick, no stringy mucus. And the thickness of endometrium that can be measured on ultrasound, it increases, which is again the sign of ovulation. If you remember our yesterday's patient, she had thin endometrium, no progesterone on day 1, on day 21, and thin endometrium. That is because she did not have ovulation, she did not have progesterone. Menstrual disorders. There are many types of menstrual disorders, starting from the absence or cessation of menstruation to painful menstruation, scant or heavy menstruations. So amenorrhea is the absence of menstrual period for 6 months or more. And amenorrhea can be primary or secondary. We are talking about primary if the patient never had menarche. But if there was menarche, even if it was just one menstruation, we are talking about secondary. So primary is due to the inability to start menstruation, due to inability to activate this pulse generator at the hypothalamus level. So this may be caused by different pituitary disorders or defect in ovarian enzymes, which does not allow secretion of hormones. Congenital adrenal hyperplasia and hyperadrenemia, different chromosomal disorders and mutations. Normally primary is accompanied by the signs of deficiency of female sex hormones, signs of hyperandrogenemia, hirsutism, acne, male pattern of baldness, and other changes. Secondary is the cessation of menstruation at a certain point when if there was at least one. So if there was menarche, it's secondary. Causes may be both physiological and pathological. Physiological is pregnancy. That's why whenever we have a patient with cessation of menstruation, the first thing that we do is pregnancy test, which was done to this patient and urine pregnancy test was negative. So pregnancy test is a must. It's the first step in diagnosis, differential diagnosis of amenorrhea. It can be lactational. We already talked about this because prolactin inhibits the release of gonadotropins. It can be the onset of menopause, and again, if it develops after the age of 40, it's physiological before pathological. It can be a high prolactin level due to the tumor secreting prolactin, prolactinoma, and mind that prolactin would inhibit the release of tropic hormones. And can cause infertility in both male and female. So it has the same action on male and female. Hypothyroidism, another cause. And finally, withdrawal of oral contraception. If contraceptives were taken by patients for years, and the most common contraceptive pills is the combination of estrogens and progesterones, body stops secreting its own hormones as the result, and withdrawal can cause amenorrhea because of the lack of hormones. Our patient is not taking any contraceptives, no pills, no contraception at all. Oligomenorrhea, it's irregular menstrual period. Menstruation does not cease because we say amenorrhea is when it stops for 6 months or more. But it may be irregular missed periods for months or 2. It's still oligo. Dysmenorrhea is painful menstruation and menstrual cramps. It may be primary or secondary. Primary if it's not associated with any pelvic disease, pelvic disorder, and secondary caused by the pelvic disorder. So primary can be caused by excessive prostaglandins, which cause contraction of the uterus, prostaglandin E2, which cause vasoconstriction, and any contraction, any muscle contraction, vascular contraction, vascular spasm causes pain. Another menstrual disorder is excessive bleeding or menorrhagia. That is either profuse, like our patient had when she had to change the pads every 1 to 2 hours, or very long, more than 1 week, really long, prolonged, sometimes lasting for 1 month, menstrual flow, sometimes for several months. The cycles can be anovulatory, and several anovulatory cycles would often lead to menorrhagia, because if the cycles are anovulatory, it means that there is no which hormone? Progesterone. There is no progesterone, and progesterone stabilizes the growth of the endometrium, prevents its excessive proliferation like caused by estrogens, so that normal cyclic pattern of endometrium changes is taking place. And if progesterone is absent for several cycles because the cycles are anovulatory and progesterone is not secreted, then there is significant proliferation of the endometrium, which ends up in shedding of the endometrium and significant bleeding. So cycles, anovulatory cycles can also cause menses. Please don't think that menses is only the result of ovulation. No. We have other indicators of ovulation, and menses is not the one of them. So menses can be even, menstrual flow can be even after anovulatory cycles, because if the cycles are anovulatory, it means that hormones are secreted by the ovarium, and this hormonal secretion is sufficient to produce changes in the endometrium, but not sufficient to cause LH surge and ovulation. That is why normal cycles that look normal, which are of the same duration with the period of menses lasting for 35 days, no abnormalities, no excessive flow, no excessive pain or whatever, but yet they can be unovulatory. And if they continue like that, this will eventually end up with menorrhagia. Polycystic ovary syndrome is again the disorder in which there are menstrual disorders, and there are numerous follicles which undergo atresia, and the common cause is high androgens level. Can be absolute, can be relative, oftentimes relative due to just low level of sex hormone binding globulin. And this causes elevated LH-FSH ratio and excessive production of androgens. Often accompanied by hirsutism, which is part of the symptoms, or one of the symptoms in the polycystic ovarian syndrome. Hormonal contraception. Again, I'm not going to go into much detail. You will study this in pharmacology. In general, we are talking about different classes of contraceptive pills. The most commonly used are estrogens and progestin pills, which provide contraception by inhibition of secretion of hormones, since the hormones are taken in the form of the pill, as a pill not secreted in the body, and that's why this hormones delivered as a pill are outside the normal hypothalamus pituitary ovarian axis, and they can inhibit the axis. Potentially they can inhibit tropic hormones release. Progesterone prevents ovulation when because progesterone rises. So if it is not given, if it's given continuously, it prevents ovulation. And the changes that are happening, they decrease the possibility of conception and implantation. Mucus is thick, and this again doesn't allow normal motility of the, decreases motility of the sperm. These combined pills of estrogens and progestins are often used to treat menorrhagia, because the progestins that are added there, they stabilize the endometrium. They block the excess of estrogen effect on the endometrium, and they inhibit the further proliferation of the endometrium, and thus are helpful in the treatment of menorrhagia. But again, if they are taken for a long time, withdrawal can cause the bleed, can cause menorrhagia. There are also progesterone only pills, because they provide contraception because of the changes to the cervical mucus. And there are also postcoital contraceptives which combine estrogens and prostaglandins. Prostaglandins increase contractility of the myometrium, and so they decrease uterine contractions and prevent implantation. So let's discuss the case. Who would like to start, please? Yeah, just the questions.
What is the normal menstrual cycle length? Is it different at adolescence and premenopause? Why? The normal is 28 plus minus 7 years. It is different.
How?
It is.
No, how, not why, how. How is it different? They are irregular simply. They can be very short, they can be long, they can be missed. So they are just irregular. Why? What happens at adolescence? That's puberty period, right? So why are the cycles irregular? Because the system, the axis is not mature yet. It's not formed. So it's not, it will take maybe a couple of years until it will be completely matured and formed and function. At perimenopause, the cause is low follicles, atretic follicles, right, less follicles, they don't secrete enough of estradiol, no LH search. For levels of control, anybody would like to do? Yes, please. And inhibins. Endometrium. Yes. What do we mean by primary and secondary amenorrhea? And what type does the patient have?
Primary is when you don't have any type of menstruation, even when you hit like puberty age.
No menarche.
No.
Let's use the word menarche because menarche we call the first menstruation. So,
And the secondary, you develop menarche, but then you stop, you became irregular. I don't remember the patient's case.
she used to have menstruations at 30 days of length,
Then it's
30 days long, right? And then they became irregular, and then she had menorrhagia. Yeah, here she is. She appears with the absence of menses for 4 months, but before, 2 months before, she had menorrhagia.
It's secondary.
Secondary, yes. What could be the cause of amenorrhea in this patient? Let's look at her again.
The stress is inhibited.
Stress, she's in stress. And that could be the reason why she gained 6 kilos in the past year. Or it could be because of hypothyroidism, right? Hypothyroidism, which itself can block the axis, can decrease the release of tropic hormones, and as we understand, low LH, no ovulation. We don't know her fasting blood glucose and fasting insulin because she is overweight. It could be changed lipid profile, and also hypothyroidism changes lipid profile and slows down metabolism. So chances are she would be having also diabetes mellitus and metabolic syndrome, which potentially again can lead to polycystic ovarian syndrome. She doesn't have it yet, right? But we have to check it. Okay, why did she develop menorrhagia?
Because on ovulation, mid bone is strong, so there's no regulation of estrogen affecting
Yes, I don't know who heard you, but I heard it. So anovulatory cycles before, no progesterone, and in the presence of estrogen only, endometrium increases proliferation as estrogen goes unopposed to progesterone. So that is why giving progesterone pills would help to treat her, or would have helped to treat her menorrhagia. Any comments? Yes, please.
It's not about the skills, but the medications. Do you have to know the contraception?
Do we have what?